The Pediatric Lounge, a podcast taking you behind the door of the physician's lounge to get a deeper insight into just what docs are talking about today. From the clinically profound to the wonderfully routine and everything in between. Pediatric Executive Development System, or PEDS, is a dynamic, transformative program designed to accelerate the growth and development of the leaders in the field of pediatric entrepreneurship. PEDS takes a hands-on approach to problem solving, addressing real-time situations within your organization. More than a theoretical course, it is a practical platform that accelerates learning. Look at our link on the show notes for more information. Good morning, George. It's Wednesday morning, and once again, we're together for the podcast and a phenomenal guest.
Yes, today is not Tuesday, and we're both actually seeing patients and working like real doctors. How do we find the time? I don't know. We just do. Today we have a fabulous guest. I've known Dr. Dan Feiten for many years, and his topic is going to be a very interesting one. It's going to be on the Beyond the Stethoscope series, and it's going to be titled From the Disc Jockey to Medical Director of a Large Tech Company and Everything in Between. Take it away.
We're pleased to welcome Dr. Dan Feiten, a highly esteemed pediatrician with a passion for T1 diabetes, or T1D, care and management. Holding a medical degree from the University of Colorado, Dr. Feiten has dedicated his career to pediatric medicine, providing exemplary health care to children and adolescents. Dr. Feiten's passion for pediatric healthcare, particularly T1D, and his commitment to integrating technological advances into healthcare delivery shines through in all his roles. His extensive education and experience makes him an invaluable leader in the field of pediatric medicine. Welcome, Dan. It's always a joy to see you.
Thank you. I'm glad to be here. Looking forward to talking.
Yeah, it's going to be a lot of fun.
Dan, I'm fascinated by the lifespan of your career, and I'm a little jealous about your voice. How is it that you started as a real disc jockey in a radio station in Colorado?
I did. So in the early 70s, FM radio was becoming a big thing. We had moved from AM radio to the high fidelity of FM radio. And of course, everything from rock music to symphonic music was popular, and stations moved to FM. But they had a sound that they wanted. And the sound back then was a deep-voiced male who spoke very slowly and very calmly, and they just emphasized the music. In fact, they even told me that we want you to talk like you have just toked on a weed. And for the 1970s, that was unique, except for the fact that I was at the University of Colorado in Boulder, and there is an area above or west of CU that is called the Hill. And the Hill back then was completely full of hippies. It was a love fest. And that was the environment that I was working in. And because my friends said, you have the voice, I decided to go into broadcasting and journalism. And so my first couple of years were studying that in Boulder. And one of my professors got me a job at the top FM radio station up on the hill. And I would go every Sunday and I would record their spots for the station, KBCO. And I would also do some commercials here and there. I was being paid $50 a spot. That was in 1972.
That was a ton of money.
Yeah, I don't know. That was probably worth, what, $250, $300? I don't know. I just thought I was so rich and so lucky to be able to get that. And then, of course, people would hear it on the radio and people would say to me, you sound like a guy I know on the radio or I've heard of. So it was fun as a young 20-something to be able to get that feedback. I also worked as a disc jockey in the evening there. Probably I wasn't working for more than a couple bucks an hour, I would suspect. I don't really even remember. But after 2 years of doing that, I said, I don't want to talk into a microphone the rest of my life. And so I quit school.
Well, and the disc jockey job, did you have 8 tracks? Is that how you did it, or someone in the sound room would turn them on and you just have to talk into the microphone?
Yeah. I hate to tell you, but it was tape. It was a big reel tape that we literally used and rolled out the commercials, and people would cut and splice everything.
Wow.
8-track came about 4 years later, I'm afraid.
Oh, wow. And
That's how old I am.
my father had one of those projectors, right? That the reels with the reels
That's
in
right.
home movies. And some of the times the bulb would get too hot and it would melt it, and you have to run and just pull it off of there and then put it together. And it broke in the middle of the movies. It was a different world. And then you did a most fascinating pivot. How does a young person in Colorado end up in India with Mother Teresa?
So when I left school, my father was a flight instructor for United Airlines. And that was how we ended up moving to Denver in the 60s. And so I had all these free passes, and I had an opportunity to basically do a solo trip around the world. And I decided to do that for the year that I was going to be taking off. And so that sounds like for the whole year. It actually was about 3 to 4 months because I couldn't afford to do anything much beyond that. But my uncle got me set up to volunteer in the Home for the Dying in Calcutta. And I was able to talk, work, meet, not only with Mother Teresa, but their entire group. And I'm sure you can imagine her humility, her grace, and her love for the poor was unlike anything I have ever experienced before. So it was a remarkable experience. I was also able to go out into the countryside and, excuse me, work in the mud huts and really see how devastating poverty was in India at the time. I would work with these physicians and what they called health assistants who would go out and work with the very, very poor folks. So I was exposed to medicine, and I was also exposed to just some really, I'll call it patient focused care, but it was really the Mother Teresa and her group. It was just their love for the poor. It was remarkable.
And so I can only imagine that being around someone like that has a tremendous long-term impact in how you view life after that and what you do with your own life.
Definitely. Definitely. I came back from Calcutta and I thought that I wanted to be in the service industry, but I did not think that I wanted to be a physician. And I even got jobs offered to me, people who would say, I can get you a job here at this hospital, etc. And I turned it down. And then after about 3 months of not having a steady job, I finally called one of the guys back and said, hey, that job as an orderly in surgery, I'll take that job. I need some money. So I did that thinking I'd do that for a month or two till I found the right opportunity. But I actually ended up staying for about 10 months. I was, this is going to sound crass, and I don't mean to make it be that way. I think it's mostly pediatricians listening. But what I realized was that the surgery residents who I was working with them, I was smarter than they were. And I'm smarter than they are. And if they could get into medical school, I can get into medical school. Yeah. So I went back and started school all over. And back then, nobody was very interested in broadcasting 101 as a class. So I went back and started all over and took about 4 to 5 years working and going to school to get through college. And then I was very fortunate to be able to attend University of Colorado School of Medicine, and very fortunate to stay in Denver because they have a phenomenal pediatric residency program. And then I was lucky to do a chief residency also.
Wow. Wow. So you really never have lived outside of Denver except your trip to India.
I'm a Navy brat, so I lived in different spots every couple of years.
Okay.
So it was nice to settle down in Denver, and my wife is from Denver, so all of her family is here. So we love what we do, and of course the weather is amazing here.
I guess you do a lot of skiing over there.
I'm not a talented skier, so at my age, I'm cutting back on that.
As long as you go down there, you don't break your neck, you're pretty good.
Yeah. As long as that doesn't happen.
Yeah, it happens, unfortunately.
Yeah.
And you're the founder and the president of Greenwood Pediatrics, right?
Yes.
How did that come about?
After I did my chief residency, I went and worked with a fantastic practice for 5 years, but felt like there were some things that I could maybe do better. And I was very fortunate that a colleague of mine was leaving his practice, and we decided to join together to create Greenwood Pediatrics in Southeast Denver. And it has been an amazing ride. And I think the reason was back then, it wasn't cool to have nurse practitioners. Patients, our parents didn't like it, etc. They wanted to see their doctor. But we felt that the team-based approach was the future of healthcare. And so we created small teams, 3 or 4 people on a team, and those people would take care of the patient. Our patients knew that 90% of the time, they were going to see Dr. Dan or my nurse practitioner. That allowed them to develop relationships with us, and things grew pretty fast. And we were very fortunate. We grew at a very rapid rate, and we got to the point where we had people who worked at Greenwood Pediatrics for 20 to 25 years. It was a phenomenal experience.
Hey, Dan, I'm curious, why, with the first practice that you worked at, why did they keep you on and make you a partner or a leader or whatever? Why did they let you go?
The nature of the practices back then, and keep in mind that this was 30 years ago.
I know.
All right. The nature was one that was maybe a little bit more a common way that people practice back then. And I tend to be very forward thinking and innovative and thinking about how do we make things better, etc. And so it wasn't so much them. It was that I had a passion to do something, and I felt like I would have more freedom to do it in a leadership position.
But I would think that if a group sees a potential physician such as you that's forward thinking, that would be an asset to the practice to bring it into the future, right?
Yeah.
Hey, that they were in their silos still.
That's one way of looking at it.
Way.
Another way of looking at it is this young guy is just always wanting to change things, change work. I'm making money. I'm going to enjoy my life. Don't bother
Now, I'm
me.
going to ask you one final question. What happened to that practice today? Where is it?
They're doing well.
They're still around.
I actually was able to include them in a pediatric building that we built where Greenwood Pediatrics was on one side of the first floor and their practice was on the other side. And in the middle was Children's Hospital with radiology and orthopedics and so forth. And then on the top floor, we had pediatric specialists. So it ended up working out really well from that perspective. And they have 2 offices now, so they're doing fine.
Okay.
How big did Greenwood Pediatrics get, or is?
Yeah, Greenwood Pediatrics, we have had 25 to 26 pediatric clinicians in 3 offices. And we got to that size about 12 years into our existence. So we became one of the largest, if not the largest, certainly the largest in Metro Denver by volume. And there were a couple of other phenomenal practices who also were large, but they had been around 20 years before we started.
Yeah.
So I've enjoyed, I have always been focused on how do we bring pediatricians together. I feel like sometimes we get the idea that's my competitor. I have rarely thought that way. I tend to think I'd rather work with my fellow pediatricians than work with somebody in private equity.
Right.
So
is Greenwood still an independent practice, or?
they are, and they're still big, 3 offices, phenomenal doctors. My co-founder, Dr. Andy Bauer, is still there, and he's just a pillar in the community. He's amazing.
That's a great story.
That's the way that it should be,
should be.
right? Pediatrics is a long game. It's not a 5-year private equity game.
Yeah.
And you become part of that community, and you keep taking care of the community, but the community also takes care of you.
Yeah.
And it's interesting that you say that, Herb, and I think this is important. I was just speaking with a person who was a chief technology officer of a healthcare company, and he has chosen to move on and do something else. He's actually opening up his own business. And the reason is that he looked back and he saw that with private equity, every 3 to 5 years, the business gets sold and you have new ownership, new ways of doing things, etc. And it's hard to get people to trust the system. And I want to be clear, private equity, there's some wonderful things about it, but as independent pediatricians, we need to understand that we may be on a turnstile every 3 to 5 years with new owners.
Yeah, unfortunately, I've seen too many stories where great organizations were taken over by systems, private equity or whatnot. The top level founders, the leaders, after a number of years were told to go away. And then the rest of their doctors are just there like cogs in the machine, and nobody's happy.
Yeah.
And they lose money on them too. $100,000 per doctor per year, I heard. Is that the number?
It's about a little more, 120 to 150 per primary care doctor.
I want to be clear, though. There are good things about private equity, and there are good spots for them to be in. In
it's not that they're
patient-centered business, we have to be careful.
Yeah.
So I think you have to really understand the private equity model. It's not good, it's not bad, it's not evil, it's not angelical. They go to Dan and George and Herb and my dad and your friends, and they go, I want to raise $5 million, but multiples, right? 50, 100, $200. And they create a limited partnership, and they're going to invest in a certain area of the economy, say medical practices. And so they raise 500 million, and they go and start buying practices. But the promise of this limited partnership is in 5 years, they return the initial investment plus the profits to the limited partners. And that's why there's a clock. In 5 years, they have to either raise more money to reinvest or sell the property to pay back the limited partners.
Yes.
If you're in a specialty like orthopedics, dermatology, there's not a relationship that lasts 20 years with your patient. You test for skin cancer. It's not skin cancer. I'll see you next time you have a mole. You broke your shoulder. I fixed your shoulder. Maybe I'll never see you again. Maybe I'll see you again. But in pediatrics, which is a neighborhood-based specialty and a relationship-based specialty, we need to invest for 20, 30 years. And that's not a model that either the government or Wall Street likes. They're not looking for that long-term return on investment. Yeah. I agree with you. It's not the right model for a long-running business, unless Warren Buffett buys you, because he never sells. Yeah. But he's private equity, right? He's got all this money, and he comes and buys great companies like a Greenwood Pediatrics and RBK Pediatrics, great leadership, great product, great reputation, and he leaves the management team intact and says, now I have the financing to help you grow, but I'm in here for the next 30 years. I'm a partner in this venture. That's not the most of people. Anyhow, you have a big passion for what I call autoimmune diabetes or type 1 diabetes. Where does that passion come from, and what do you want to do with it?
Yeah. So my wife and I have been blessed with 4 children now in their 20s and 30s. And 3 of our children, our 3 sons, all developed type 1 diabetes before they were 2 years of age.
Wow.
So think back 25 years ago to 32 years ago. We didn't have continuous glucose monitors. We basically did finger pokes 4 to 6 times a day. We gave insulin shots at least twice a day, so that we were giving, with 3 kids, we were giving 40 shots a week and maybe 90 plus finger pokes a week.
Wow.
And let me be clear, that was my wife doing that while I was busy working at the office and coming home at 7 or 8 o'clock every night. So she's amazing. So we have a passion for that because our kids have it.
I have 2 questions about that.
Yeah.
How do you even diagnose diabetes on a 2-year-old? How did you know? He just got dehydrated?
They get lots of wet diapers.
Yeah. For our first son, I remember coming home and seeing some excessive thirst and frequent wet diapers. And I actually called my friend Andy Bauer, who was working at the other practice. This was right before we started Greenwood Pediatrics. And he saw him immediately, and we made the diagnosis. With my other 2 kids, we were able to do a little bit of antibody work, but it was not as sophisticated back then. We just knew that they each had 1 antibody, and we knew that was a possibility. Our 3rd child ended up having DKA, was in the ICU, etc. And
So tell me a little bit more of that, if you don't mind sharing, because I'm traumatized by the memories as a resident taking care of kids in the PICU with DKA.
Oh, yeah.
It's just a horrible disease. And I just kept remembering the endocrinologist was always screaming. She wasn't screaming, but I was always saying, do not hydrate him too fast. You'll cause brain edema. They'll herniate and they'll die. Once the kid's dehydrated, what do you want me to do? Be careful. That fluid shift will kill the kid.
yeah,
Luckily, I never saw anybody died, but it was so stressful to see a kid basically in shock. And you're worried about pushing ebolas because they might herniate. And I cannot imagine, from the parent's perspective, having your 2-year-old in the PICU with DKA. That had been tremendously traumatic for you and your wife.
when our 3rd son, he became ill with an upper respiratory infection, and I went to work on a Saturday morning. And when I came home and I saw his color, I literally just picked him up, said, I'm heading over to the hospital, call Andy, call the hospital, and they were there to meet us. Now, keep in mind that in Colorado, we have one of the top diabetes centers, the Barbara Davis Center for Childhood Diabetes. And so I was fortunate that we had top level individuals who, first of all, already knew us because of our other kids. And they were there, and literally they took our child out of my arms, started and got him hydrated at the appropriate level. And of course, in my brain, I'm going cerebral edema, cognitive impairment, etc.
Yeah.
But it turned out extremely well, thanks to the fact that there were phenomenal people at the Barbara Davis Center and
So
children's.
that was a children's hospital, a children's ER.
Yeah, children's.
Could you imagine if you would have walked into a regular hospital where they have no pediatricians?
They would have started an IB. Yeah.
And
Yeah.
called out.
And flooded the kid.
Yeah, 2 years of age, I can't have diabetes. That's what they would say.
Yeah. And so when you started this journey, did you have Lente, long-acting insulin, or was it all regular insulin?
No, we were giving Lente. Yeah. Yeah.
Okay.
So
and then
Lente in the day or in the morning with a little bit of a short
so
act
regular.
at that time. Yeah. And then we would use a short acting at the dinner time. And then I remember we used some milk with cornstarch and we didn't quite have protein supplements back then. We had it, but nobody really knew what it was. And so we used things like cornstarch to thicken their drink at night so they would not go low in the middle of the night.
And the concept of diabetes, or autoimmune diabetes in particular, has really changed since we went to medical school.
Yes.
Right. First of all, we know it's not juvenile onset because a lot of early adults get type 1 diabetes.
Correct.
And second of all, and I've learned this from you, you can now diagnose diabetes very early on by drawing 4 auto tests that are available at LabCorp and Quest. And that informs you that the child is a diabetic, an autoimmune diabetic, before they require insulin.
Yeah.
You have done a
Greenwood
study.
Greenwood Pediatrics, Herb, we volunteered to be one of the first practices in the country to do what we call ASK or ASK study, autoimmune screening in kids. And eventually that study screened, I think it was 60 to 70,000 patients to look and see whether or not they had some of the antibodies that would predict the possible onset of type 1 diabetes. And so you've got kids who have 1 antibody, but once you get to 2 antibodies, you've got type 2, and that gets confusing for folks, but it's just the level that you're at. And you have an increased risk of developing diabetes. And we can even, they can even predict now the kids that are much more likely to get diabetes. So that means that for siblings of kids with type 1 diabetes, we can do these antibody screenings to look and see when they might show up with a second, third, fourth antibody.
So I'm going to come back to that in a minute, but I just want, from the logistical point of view, you're a large practice, there's almost 30 clinicians. I don't know how many patient visits you did a year, but it's got to be over 100,000. And how did you, the logistics, did you test at 2, 6, and 9, everybody in your practice, or just everybody at once? How did you do that?
There was an age range as part of the study. And as I remember it, I believe it started at 1 year of age and then could go up into the teen years. And we literally had cards that we said, hey, if you're interested in being part of this study, we can move you over to this section of the building, and they'll take a history and go through the process, and then they'll do a finger poke or draw some blood. And that's how we got the kids tested. And I was surprised how many people know someone with diabetes. And so they were interested in getting their kids checked. We all know this. Parents will do anything for their kids and to provide prevention, etc. So it warmed my heart to see how many people wanted to contribute to science, essentially.
How did you fund this?
It was a grant through Children's Diabetes Foundation.
Oh,
they came to me and said, hey, can we do this at Greenwood Pediatrics? And then it expanded to the clinics at Children's Hospital, expanded to clinics throughout the country. And then there were several other studies in other countries where they also were tracking. And we developed this database of understanding and being able to predict what the outcomes could be. Now, we haven't talked about population health, but this is a great example of where we need to go for pediatrics in population health. Identifying specific populations, kids with type 1 diabetes, or kids with complex conditions, or kids with asthma, kids with depression, etc. And we need to pull that data together to find those trends, find those, I'm trying to think of the word, the things that cause delay in healthcare and that are roadblocks for kids to get the care that we need. And once we gather the population health data, that will allow us to solve some of these problems. And that's what the payers.
So did you find that this was overly burdensome for your practice? Was this difficult for your practice? Did it cost a lot of money for your practice to do all the screening?
No, now understand that my team of 3 or 4 individuals was much more passionate about it than other partners. That's not a criticism. That was just natural. And so I probably sent more people over there. And also keep in mind that I I probably had the largest number of families whose kids have type 1 diabetes. They heard that Feiten had kids with diabetes. And so I just ended up being the diabetes pediatrician in Metro Denver.
And then
So
another
I had
question.
more kids with diabetes, so more siblings also.
Right.
And then another question is, did you find that once somebody was positive for 2 antibodies, that it became a complicated problem for you and your team to handle because the mom is upset and we don't have access to mental health resources? And was that a problem for your practice, or were you able to have a conversation like we do when a child has an LDL that's elevated,
Yeah.
or a blood pressure that's abnormal, or has 2+ blood in the urine, and I can explain and redo the test, and if the urine does come back positive again, first thing in the morning, send them over to the nephrologist. Was it a big burden in your practice to do that counseling?
It wasn't, because the blood and the studies all went to the Barbara Davis Center first, where they were doing the research. And then if somebody had 2 or more antibodies, they would contact me, but they also contacted the family and said, here's what we see, here's what these numbers mean, etc. We've shared this information with Dr. Feiten, and generally then I would call the parents later on that day and discuss it with them.
But it had to be a very long conversation that you had.
Again, keep in mind that some of these parents already have other kids with type 1 diabetes.
But still, you're telling somebody that your kid is going to have a chronic illness in the future. You don't know when.
Oh, yeah.
You don't just
yeah.
call up and say, hey, your test was positive. Have a nice day.
Oh, absolutely.
Back in
Yeah,
those days, I assure you, telehealth didn't exist.
that's right.
They didn't come to the office, so you couldn't put an office visit. You stayed on the phone for a half hour, probably for free.
Yeah, for free. Yeah,
That's
you're
the point.
absolutely right.
Well,
Good point.
that we have to have that conversation, because that's a whole other conversation,
Yep.
which is the American financing of healthcare at this moment is not prepared for any population health, any intervention that delays disease or prevents disease. We are only set up to treat disease.
Yes.
The more catastrophic the disease, the more profitable the treatment is. So, and no one really, not the American Academy of Pediatrics, not the people in Washington, not the thought leaders, want to have that conversation, because it is an extremely difficult conversation to have. But more and more, there are medications like T-Sealed, like the CRISP technology for kids with sickle cell disease,
Yeah.
like the medication for kids with hemophilia, that are coming out, that are not only going to change the course of the disease, might prevent the disease altogether. And we don't know how to finance them. Some of these treatments are moderately expensive. $180,000 is moderate compared to the $2.5 million for the sickle cell disease and the $2 million for the kid with hemophilia. But the amount of money saved when you now have to have infusions and frequent trips to the emergency room, and just the quality of life, is unbelievable. But we don't know how to finance that. But that's for another conversation. I really want to tease out, why is it so important? So I am more nuanced than you are and less experienced with autoimmune diabetes. I think that once you have 2 positive antibodies, you are like the person with an elevated LDL cholesterol. You have diabetes. You have hyperlipidemia. You have not had your pancreas blown out yet. You have not lost your eyesight. Your kidneys still work, and you don't have your toes amputated yet. All late stages of a very difficult disease. But you already have autoimmune diabetes. What is that big gain of knowing before they become symptomatic? Polydipsia, polyuria, weight loss, that they are diabetic.
One of the key features is the severity of DKA with the onset of type 1 diabetes. And so determining early on if a child, and right now I'm just going to focus on siblings, all right, because that's the first step. Identifying siblings who are at risk for that we can, siblings or close relatives, I should say, we can then be able to track that and be able to see the onset of type 1 and prevent DKA, essentially.
And why is preventing DKA important? We have great ICUs in children's hospitals. So what is so tragic about DKA other than it's got to be a horrific experience as a child and a parent?
George gave the answer. There's too many hospitals without pediatric experience now. There's too many urgent cares without pediatric experience. That's not necessarily their fault, but we all know that hospitals are moving away from pediatric care. They're closing down their pediatric wards. They don't see those kids that come in early. And there is a significant portion of the population that are at risk because of their lack of resources for pediatric expertise.
Pediatric Executive Development System, or PEDS, is a dynamic, transformative program designed to accelerate the growth and development of the leaders in the field of pediatric entrepreneurship. PEDS takes a hands-on approach to problem solving, addressing real-time situations within your organization. More than a theoretical course, it is a practical platform that accelerates learning. Look at our link on the show notes for more information.
But these big centers, the children's centers, where they have all the specialists and all the things that you need. I have a case of a kid that needed to go to our big center here, Twin ENT. 6-month waiting period to see an ENT. Back in the day, hey, can you see him? I'll see him tomorrow.
Yeah, that's a little different in Denver because Barbara Davis is such a phenomenal center and has so many people doing research on type 1 diabetes in children that it is a very different experience than anywhere else in the country. But you raised a couple of questions in my mind. One, this is a health equity problem because the people that are highest risk for presenting with DKA are those that are insured by Medicaid, and those that are not white, and those that are very young. And it's for the reasons that you alluded to before, lack of access, because Medicaid doesn't pay enough in most states to maintain pediatric offices open, let alone the pediatric endocrinologist. Number two, DKA has a long-term devastating effect on children. And that effect is the risk of death from cerebral edema. Half to 1%. Some people say up to 2%. Much worse if you're in a small town past Vail, where you have a local ER and there's a storm. They can't ship that baby to the children's hospital via helicopter quickly.
Right.
But that's the reality of Alabama too, right? They have 60% of the counties don't have a pediatrician. Okay. And so that's a first risk. There's good study that shows that you lose memory after a DKA episode. There's good studies that show that your IQ and your verbal ability decreases after you have an episode of DKA. And 50% of U.S. kids present with DKA at time of diagnosis with diabetes.
Right.
So anything that we can do to reverse that trend not only saves the $20,000, $30,000 in the admission cost, it decreases the burden on that individual to protect their brain and have brain harm that's long lasting.
Exactly.
In addition to that, you guys out there in Denver did a beautiful study at Barbara Davis where you looked at 15 years worth of data. And the kids that present with DKA always have higher hemoglobin A1Cs. And they turned it out for 15 years. The ones with mild DKA have an elevation. the ones with severe decay, even bigger elevation. And we know from the big study in adults that a 10% decrease in your hemoglobin A1C will decrease your burden of retinopathy by 40%. So every 10% that we decrease, we are stopping end organ damage. And the longer we can stop that end organ damage, just like with hypertension, we don't treat hypertension because it causes you pain. We treat it because over 40 years, it kills your kidneys or causes you to have a stroke. And so we need to think of diabetes at this moment in the same way. We are treating for the long. We're trying to prevent these end organ damage before it happens. And I think that is the crux of the problem right now. That we have the autoantibodies, we can prevent DKA. And Barbara Davis has shown that you can decrease it by 90% if you know and you're following these kids with a simple test every 6 months.
Right.
Testing glucose, hemoglobin A1C. As soon as they start drifting into the pre-diabetic range, then you intervene. And I think that's the importance. We don't want to see more kids with DKA and long-term brain damage and long-term metabolic damage that leads to more end organ damage. Their lifespan of a diabetic is 10 years shorter than a non-diabetic. So there's a great opportunity here to do population health, to intervene early, to prevent excess money being spent in care, and to help these kids and these families avoid a really horrible experience.
I agree. Obviously, I'm biased, but the opportunity to take data that we can use to track and develop guidelines for managing these kids, because as you said, end organ damage, it happens either quickly with one event or one insult, but it also happens slowly over time. It's a great disease to use when we look at the power of population health.
Yeah. Yeah. Now, you've done so many things. You're fascinating, man. I'm gonna say you're a Renaissance man.
Ask my kids that. They may not say that.
Sure.
But by the way, I do want to mention that all of my kids are much smarter than I am. They have not had that end organ damage. They're doing it incredibly well.
Oh, that's beautiful to hear. That's awesome to hear. And you started, while you were running this big ship, you started something called RemedyConnect.
Yes.
And why did you start that? And what is RemedyConnect?
I think I have mentioned to you all before that I have been a big fan of not only pediatricians working together, but using the voice of the customer, the voice of patient. And so in our first year at Greenwood Pediatrics, I asked 8 mothers to meet with me on a monthly basis. In the evening, we just had some pizza and we had meetings to talk about what do they need out of Greenwood Pediatrics. And essentially the answer was, we need resources. We need you to be able to tell us when we need to worry at night, when we need to call you, or what can we do at home, etc. And we actually created a book that we handed out to all of our patients. They designed it, called it the Owner's Manual, and lots of cute pictures and concepts of cars and autos and so forth. But it provided in the back that first pediatric symptom checker. And I worked with my friend and colleague, Dr. Bart Schmidt, on that book. And he took it and expanded it. And one summer, he literally put together the pediatric symptom checker that we now provide through RemedyConnect. And now the American Academy of Pediatrics provides that. And that started out with just listening to mothers, listening to what their needs were. And so mothers started telling, when the web came along, people said we need to get this content on these websites. And so we did that at Greenwood Pediatrics, and this symptom checker spread throughout the country. We had people calling us saying, hey, what is this? How do I get it on my own website, etc.? And that's how RemedyConnect was born. And then we built in a digital telecommunications hub so that we could have nighttime care for parents. We created a pediatric telehealth application through RemedyConnect, and it really grew without a lot of marketing. We were very fortunate.
And so everything I know about marketing in the internet, I learned from you. What's SEO and what is E? And why is that important to a business, any business?
Yeah, great question. I like to put both of those under the term findability. And the goal in digital marketing for pediatric practices is to make yourself findable. That's on your website. That's through your social media. That's through your friends telling others about your amazing practice. But in terms of SEO, you are optimizing information that is important to Google. Why? Because Google's value comes from the fact that their goal is to provide relevant information to the searcher. And it's that relevant information that becomes so important. So you have to use specific keywords, but you also have to use specific code and metadata in order to tell Google, this is why this is relevant. And then the second part of that is that EAT or EAT, Google for professional groups is looking for expertise, authority or authoritativeness, and trustworthiness. They want to be able to send people to your site and feel comfortable that this is trustworthy information. And so part of I probably preach too much that a content strategy for your website and for your social media is critical for SEO and for establishing with Google that you are an expert, you are an authority, and you are trustworthy.
And without that, people won't find you, because the referrals of old days where Dan is at the OB in town and we go skiing together and he sends me the babies and everybody's happy. That doesn't happen anymore.
Oh, we're showing our age, guys.
Yes, but it's true. The mothers Google stuff. And
that's the way it used to be.
And now, this is the first time I heard from anybody this concept was from you. And it's the word hyperlocal.
Yeah.
What changed at Google, and what does hyperlocal mean for a pediatric practice?
So Google wants to provide relevant local information. You don't want to know about the pediatric practice 80 miles away or in another state. You want something that is relevant and close to you. And so Google created a system, which even Apple has copied, but they've created a system whereby in your Google business profile, you are responsible for giving Google all of the important information that it needs about you. And Google uses your Google business profile, and now Apple uses Apple Business Connect as the truth. And if your phone number is wrong on your Google business profile, you're in trouble. I literally have seen practices that don't show up on Google Maps because they have the wrong phone number.
Or your hours of operations.
Yeah, your hours of operation. And so people can quite simply put their focus on making sure their Google business profile is updated every 2 weeks. Always post something to your Google business profile. That's the cheapest, easiest, cost-effective way to get yourself to stay higher on the rankings.
And also mind your 5-star reviews, that there are plenty of them. and that they're
responded to.
responded to, but also that they're
the
current.
review.
So this Google stuff is important and the reviews are important. But as Dan, most of the people, they'll just, I guess at a restaurant, they won't do it. But if they get angry with you, they get angry usually because they had to wait or there's some money issue or there's something. And they'll post a negative review about a physician, which is terrible. They rarely will go out of their way unless you did something life altering for them to post a positive thing. I love Dr. Bravo. He's such a great guy. But if he kicks me off, I will definitely go out of my way to post. So it's not quite fair for physicians, I think.
I think that at least what's worked for us at Greenwood and other practices is that when I get someone who says, boy, I really appreciate it, or thank you for the good work, blah, 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 I have not been hesitant to say, thank you so much. And we literally had a little card with a QR code that would say, do you mind posting that to Google? And maybe 30% of the folks would actually do it. But that in and of itself is the ability to pull out those people that we know really appreciate us and like us.
Right. That's very important. So now you're the medical director of a big, large tech company, Office Practicum.
Yeah.
How's that doing? You have some big shoes to fill over there after Dr. Presley.
Ooh,
I don't know if you can fill them.
I can't. I
I don't
absolutely
think anybody
can't.
can, but you're up and coming AAP president, thank God. Everybody loves Sue, and she's a good leader.
It was not fair, I'll say that. But in the end, and I think that all of us have different gifts that we bring to the table. Right. Dr. Suzanne Berman, oh my goodness, to work with her, she is just amazing.
Yes.
Just phenomenal.
She's very smart.
But she and I often talk that her gifts are not my gifts. My gifts are in strategy, what's coming down the pike, and what are the things that pediatricians need to be thinking about in order to stay independent.
Correct. I agree with you on that. And independent practice, I shared with you a text a few weeks ago after we had our advisory thing. That made me really sad because I know that doctor was a great doctor. He'd been doing it for a very long time. He was the poster boy for independent practices. And then all of a sudden, poof. And you think about it, all of our clients, the mothers are usually young people. They're kids themselves sometimes.
Yeah.
So they know computer technology better than we do. Office Practicum is a great product. I use it myself in the office. I tell Sue Presley that she basically saved our practice in 2016.
Wow.
When we had a really good, for a physician point of view, product.
Yeah.
That was taken over by some bigger other EHR predator and just shut it down and killed it. And I view you guys at Office Practicum as an independent practice, PCC as an independent practice. You guys are not the monstrosities.
That's right.
And my fear is always, what if a company like Epic or Athena or something comes and says, goodbye, Office Practicum. Dr. Rogu, you have to use our product now. Yeah. I think that would be the end of RBK.
Hard to know, hard to predict, but the challenge that I see as the chief medical officer is the same thing that Google wants to accomplish. I want to identify the most relevant workflows, fixes, enhancements, etc., that we need to put together for independent pediatricians to help get our work done. The issue comes that there's a lot of different opinions as to what is most relevant. I think we are now narrowing down that focus, and I'm excited that we have some very strong focus in terms of where we're going in the future. And I can't tell you what's going to happen if Epic is going to take over the world, etc. I do think that there are ways that we pediatricians need to rethink where healthcare is going. I think you guys know that I talk about networks and the role of networks in healthcare, whether or not it is a hospital network or a payer network. We also have provider networks and more specifically, patient networks. And my hope is that we pediatricians will recognize the importance of us working together. As I said earlier, if you've been working with pediatricians in your office for the last 10, 15 years, I don't know that you want to go work for a financial institution. You'd rather work with other pediatricians. And we are looking to create capabilities for pediatricians to work together. We have engaged a prominent healthcare group of attorneys. We are looking at the supergroup model. We're enabling one supergroup right now to be able to come together and form that model. We're looking at the other models, and we intend to focus in on how our business intelligence tool, our reporting tools that are coming out in the next year, we're focused on how that will provide us the opportunity to report on each specific population with more than 20 plus years of data. So that's what keeps me going. That's what excites me.
Right.
Supergroups won't be for everybody, but they're one part of the model. I think that we're on the path to discovering that and really moving further into the whole concept of pediatric-specific networks.
Mm-hmm. The networks, I think, are important. The one monstrosity of a supergroup, I'm not so sure.
Mm-hmm.
But I do see the value of one large supergroup that beneath it has 50 other little supergroups for each.
You got it.
No, and then because it's hard, you got pockets here, pockets. I mean, even in New York, we have our own clinically integrated network, but it's our local thing. We can't help anybody in Pennsylvania or New Jersey.
That's right.
We don't know the market, but we need something to connect all the little ones.
Healthcare has to be local.
Mm-hmm.
And so I'm not sure if I would call it one large supergroup, but it would be one large entity that has the reporting capability and the ability to pull that data together and let people govern their care more locally. Yeah, I think you're right.
Unfortunately, medicine has become like gang warfare.
Yeah.
So you need the big protectors and the little gangs on the street.
Yeah.
And they have to be organized.
That model has been used for a long time in law, in accounting. The big accounting firms are global, but then hyper-local.
Exactly.
And so are the big law firms, right? They got offices in London and they got offices in New York and San Francisco. But the partners in San Francisco don't know what the partners in New York are doing because the laws are different. And in San Francisco, you have to be all tech driven. In New York's financial industry. So that model has been there, and that could work in medicine if we could work together.
It could work.
Yeah, I agree.
But it needs something at the top level to lead it. And I think if you have the technology, you could make the top level and lead it. I always wondered why PCC or Office Practicum didn't make their own clinically integrated network with all their clients. But they're not physicians.
We're looking at the possibilities.
That's good.
Right now, giving some serious deep dive into it and trying to understand the structures that we need to help put together in order to help independent practices survive.
If the practices survive, or peace survives, you got the technology, the resources, the people, the predators go away. They don't even come anymore. It was very interesting. I used to get poached in my practice every other week by someone.
Wow.
Since we developed that clinically integrated network of independent practices with their own individual tax ID numbers, nobody bothers us anymore. They just don't come. We appear to be a big gang. It's crazy.
Well, yeah, there's lots of ways to try to resolve this. Who knows how it'll out. But I'm glad you guys are at least thinking about the problems and how to keep independent practices going, because I think it's important for the neighborhoods. Now, I think your users conference is coming in Las Vegas in April.
That's right. OP Users Conference.
Is there anything in particular you're very excited about that you can share with the audience?
Oh, wow. We'll have the usual speakers. Mark is coming from the American Academy of Pediatrics. He's going to talk and give one of the keynotes. Gosh, whole host of folks. I'm really just excited for the opportunity for people to come together. The Users Conference is such a great opportunity at lunchtime, at break times, in the middle of the presentations, just meeting and talking and sharing ideas and how you make things work.
I think the user conferences are very important. We're coming all the way there from New York.
You're going to make it,
I usually bring a gang of people.
Yeah.
I'm not an OP user, unfortunately, but I'm going to come just so that I can hang around the great people in pediatrics.
Oh, boy. There's going to be some. You're going to have all the top people.
I very much look forward to seeing you in Las Vegas. That should be a lot of fun.
Good.
Thank you for your time. It's always such a pleasure to talk to you.
Yeah, it was a lot of fun, and I got to go back and save the world. And Herb's going back to solutions also, because that's what we went to school for. Not for
I guess that's what we'll have to do.
Yeah, that's our.
I wanted to take a minute before we end the show today for a big ask. I would ask you to please go to the website for Ask the Experts. This is a wonderful program from Barbara Davis Center for Diabetes in Aurora, Colorado. The whole definition of what insulin-dependent diabetes, juvenile diabetes, type 1 diabetes, or autoimmune diabetes has changed. Please do your part to try to prevent DKA in children, as it has a long-lasting effect on their brains and their metabolic health. Thank you. As you all know, I am a huge fan of the 59th Annual Pediatric Postgraduate Course, Practical Updates and Cutting-Edge Topics for Pediatricians, founded by Dr. Donald H. Altman. This year, the meeting will be held in Coral Gables, March 22 through 24 at the Lowe's Hotel. Make sure to visit their website and register and see Dr. Rogu and I at the CME. Thank you for listening. Thank you for listening. This has been a production of the Pediatric Lounge. On the show notes, you will find links to our co-host and other important notes, as well as a timetable of the topics discussed today. Don't forget to follow us on social media and subscribe to wherever you listen to your podcast. Leave us a great review, as it helps us greatly. In the meantime, we will see you next week. The Pediatric Lounge. The conversations are not intended as medical advice, and the opinions expressed are solely those of the host and the guest.